Thanks for joining us for a three-part roundtable discussion on the current topics of Parkinson's disease. I'm Dr. Winston Wong, formerly from the payer arena and currently an independent consultant, and I will be moderating this roundtable discussion. The goal of this multidisciplinary roundtable is to go and review the Parkinson's disease from the aspect of therapy options, management challenges, and reimbursement considerations from a physician, payer, and pharmacist perspective. For this series, we are joined by the following experts. Dr. Yasser Torres Yagi is the director of the Parkinsonism and Dementia Clinic at the MedStar Georgetown University Hospital. He's also the co-director of the Movement Disorders Fellowship at the Parkinson's Foundation Center of Excellence and an assistant professor of neurology at the Georgetown University School of Medicine. Dr. Yagi will be representing the physician perspective. Dr. Patty Today Allen is the VP of Clinical Programs and Services at Welldyne. Dr. Today Allen will be representing the pharmacist perspective. Dr. Barney Spivak will be representing the payer perspective. On the screen, you will see the disclaimer and faculty disclosures for this activity. For part one of our discussion today, we will review our current understanding of Parkinson's disease and the goals of therapy. Before we get into the discussion, we'd like to go around and hear each of your thoughts on why this discussion is important and more about your role in the patient journey. Dr. Yagi?
Thank you for that wonderful question. It's nice to be here. Thank you, everybody, for participating in such an important conversation and discussion. To me, one of my passions as a clinician is to understand the context of the advancement in therapeutics when it comes to the care for our Parkinson's patients and all of our patients that are getting older and aging. I think there needs to be a strong focus on creating this sort of pathway for advanced therapeutics and new therapeutics to become available as we move forward with our clinical care. When we think about Parkinson's disease, it is a very, very important time because of the advancement in therapeutics. Understanding where it is in the clinical spectrum of all of our Parkinson's disease patients and what sort of therapeutic adjustments or therapeutic interventions we can initiate or augment in terms of adjunctive therapies to better treat our patients. So for me, one of the most important objectives to this roundtable discussion is to focus on this effective management and proactive management of our Parkinson's disease patients, at least from a physician standpoint. What I teach our medical students, our residents, our fellows, me having been a fellow not long ago, learning the subspecialty field of Parkinson's disease, because of these advancements in therapies, post 2015, we've had a multitude of medications become available. Learning how to help our patients access these medications is very, very important. And learning how to teach my colleagues, my subspecialty and general neurology colleagues on how to administer these medications in a safe and effective manner is very, very important.
Dr. Spivak?
Yes, hi, good morning, and thank you for the opportunity to be part of this roundtable discussion. My focus, again, as a trained internist and geriatrician, as well as a medical director for a health services and technology organization and payer organization, is to really ensure that we're doing the best that we can to enrich the lives of older adults and to try to improve the system of care that exists for those who have Parkinson's, as well as for their caregivers who are attempting to optimize their day-to-day management. Again, my focus, again, in terms of population health, in terms of chronic condition management, and in terms of utilization management, is to really try to improve the measures that we can impact that will make a significant difference in improving the outcomes for those who have Parkinson's. Specifically, this may be in terms of adherence, focusing on medication and non-pharmacologic management adherence, trying to decrease any potentially avoidable healthcare utilization, as Dr. Yagi indicated, to try to improve our delivery of effective healthcare and high value of healthcare. That's really the focus that we have as payers as well as clinicians. And we're trying to do our best to improve the quality outcomes, the quality care that's delivered to those who have Parkinson's, and to do our best to promote and utilize evidence-based medical management, as well as non-medical management sometimes, to optimize the care and outcomes and the well-being of the older adults that we serve. We're trying to promote the best outcomes by improving home and community-based care, to try to improve the supports that we can put into place to decrease any problems in terms of what are called social determinants of health, as well as improve the overall management and care that's provided to those who have Parkinson's. Ultimately, we're trying to improve the quality of life for the older adults that we're serving, and to decrease the burden of this disease, which, as Dr. Yagi had mentioned, is a significant contributor to impairment in older adults, and it's a common problem. It affects, as we'll, I'm sure, learn later on, maybe as many as 3% of those above the age of 80. So it's a very common and potentially disabling problem that older adults and their family members and other loved ones around them are trying to deal with. This is also especially important for me as a geriatrician. Again, we're confronted with many older adults who not only have one problem, Parkinson's disease, but have multiple chronic problems, multiple chronic impairments. And to try to optimize the attention that's paid to this particular problem within the context of all the other chronic conditions and impairments that may affect the older adult is really the focus of our energies. And ultimately, as I said, we're trying to enrich the lives of older adults and do the best that we can to ensure that care is provided equitably, it's provided effectively, and that we deliver high value in what we do.
And Dr. Today Allen.
Thanks so much. And again, I'm also, to echo the sentiments of Drs. Yaki and Dr. Spivak, I'm also very happy and to be here and to have this very important discussion. From a pharmacist's perspective, one of the big challenges with Parkinson's disease patients is that adherence is a challenge. It can be a challenge. These are patients, from a quality of life perspective, they're on multiple doses a day, and that's just for their treatment of Parkinson's disease, not just all their other chronic conditions. And so as a pharmacist, from a pharmacist's perspective, being able to work with the providers and working with the patients and their caregivers, because let's not forget caregivers are also heavily impacted by patients who have Parkinson's disease. Helping them better understand and come up with better ways to maybe help improve their adherence, help mitigate some of their side effects, and ensure that other medications that they're taking will not be having any kind of issues with their Parkinson's disease medications. Another element that's very important to me too, from that I think about, is that this is an aging population in the United States, and the elderly population is going to be dramatically increasing over the next 10 to 20 years. And so it's something that we need to make sure we have infrastructure in place to be able to help these patients with Parkinson's disease, because the number of patients is going to grow.
Thank you very much for those informative insights. So let's begin our discussion. What are the common symptoms that leads one to first suspect Parkinson's disease, and at what stage of the disease is it usually first diagnosed?
I can take that one. Thank you for asking. When we talk about Parkinson's disease, it's so important to understand that it's a condition that's very much a spectrum disorder. And so we always need to put on our clinical detective hats when trying to diagnose Parkinson's disease early. I can't agree more with my colleagues here on the panel. being proactive, not just therapeutically, but being proactive diagnostically is important. And it can make a big difference and a very big positive impact on a person's life, because you can equip patients if you know exactly what the diagnoses are, what you're dealing with, and what other comorbid non-motor symptoms our patients might be dealing with. That can be very, very helpful. To further answer your question, the way we do this is we utilize clinical examination. Neurology is very much a clinical examination-based subspecialty or specialty. You know, we utilize our clinical exam, our neurologic movement disorders exam, and it can be something as simple as walking someone down the hallway, walking next to them, watching them walk, looking at their arm swing, seeing how fast they're walking, how their stride length is or isn't affected, watching someone just sit in a chair and see if we see a rest tremor, feeling someone's joints or moving their limbs to see if there's any rigidity. Sometimes these features can be very subtle, but very impactful at the same time. When we think about Parkinson's disease as a motor phenomena, that certainly is the case. If you think about 204 years ago when James Parkinson first described those cases walking down the streets of London, or his own patients, he basically named his essay the essay of shaking palsy. But we know now there's so much more to Parkinson's disease, more than tremor. Oftentimes we don't even have a tremor when diagnosing Parkinson's. We look for bradykinesia, which just means slowness of movement. And so as a geriatrician, I'm sure Dr. Spivak can understand that there's a large number of our patients that might be walking slowly, right? And so I would believe, and I would argue, that Parkinson's disease can be a very underdetected, underdiagnosed disease, especially in our aging population. And then when we add in the non-motor symptoms of Parkinson's disease, those tend to be very much underdetected as well. Those are things like difficulty with sense of smell, constipation, depression, anxiety, pain, sleep disorders like acting out of our dreams with REM behavioral disorder, or sleep fragmentation, which really affects our patients. Our patients can have restless leg syndrome or obstructive sleep apnea as a byproduct of their tight musculature with Parkinson's disease. Cognitive impairment, dementia, psychosis. So, you know, we always have to think about this disease and this condition as a multifaceted disorder that affects not just the brain, but all the organ systems in our body. And that's why it's so important to have a team like the one we have here on the panel of pharmacists and geriatrics and the payer and the clinician having a discussion on how we can better treat our patients and diagnose them properly.
So what common symptoms would actually spark a referral, let's say, to your clinic? Because what you referred to is the sort of the evaluation once they hit your clinic. What drives the patient to the clinic?
Wow, what an important question. And our evaluations, when we first see patients in a big tertiary care center like ours, we have close to 13,000 Parkinson's patients. And one of the first things I tell them is, we're probably going to have about a 90-minute encounter. A 90-minute encounter, which means 90 minutes trying to understand that diagnostic journey. Because that diagnostic journey can be so long and can be frustrating for a patient and family, can be not a straightforward A to B type of process, but very much a complex, curvy road to our clinic. Sometimes we get referrals from general neurologists. Sometimes we have referrals from general practitioners or geriatricians. A lot of our patients actually are self-referred, and so this understanding of one's own symptoms sometimes, you know, with the access now to data and information and evidence-based literature, our patients can read up on the internet and try and do their own research and find their way to the right subspecialty clinic. I would say that we see patients all along that spectrum, and when they finally enter into our clinic, a lot of the times even just the diagnosis that we give them of a Parkinson's disease diagnosis in some ways is relieving, because they have tried so hard and they've been working so long on trying to figure out what could be wrong with them, especially in these cases where our patients may not have the kind of straightforward overt cardinal features of Parkinson's disease. When we think about things like rigidity, stiffness, slowness of movement, gait impairment, a lot of the times those things can be misdiagnosed, or classified as another type of problem. For example, a patient might go in, say, I'm feeling stiffness in my leg, might first go see their geriatrician or their primary care doctor, who refers them to see an orthopedist, who then refers them to go perhaps see a physiatrist or a physical medicine and rehabilitation doctor. And so a lot of our patients may unfortunately have seen a multitude of other physicians prior to being referred to our clinic.
If I could just follow up on that question and indicate some other comments regarding what Dr. Yagi just indicated. I think it's important, as was mentioned, that when people are seen early or managed early in terms of Parkinson's disease, a geriatrician or primary care physician can probably manage that person pretty well. In other words, once treatment is started, it may take months for there to be problems that come up in terms of some of the motor fluctuations and so on. So early on, I think it's okay and preferable to have primary care and probably a geriatrician involved, depending upon the issues that the patient may have. But once there are problems that come up in terms of choice of medication, management of some of the problem motor features of the condition, managing some of the non-motor, maybe less common features, and when there are questions in terms of overall care, I think there's no question that a neurologist or movement disorder specialist within neurology might be an appropriate and necessary component of the care team. So, before we get into, an advanced stage of disease, when there's much more likely to be problems in terms of managing, I think it's a good idea, as we've heard, to have the expertise of a specialist involved in terms of trying to identify appropriate strategies to manage that individual, and also not to forget about adding in non-pharmacologic approaches early on. As was mentioned, I think, as a geriatrician, one of the common things that we see, obviously, is falls and fall problems. So again, when we're seeing someone who may have Parkinson's disease, who presents early with falls, or presents atypically in some other ways with, tremors in both hands at the outset, for example, or with more rapid progression, or with, a failed trial to levodopa, let's say, the medication that really should be responsive, that the individual should be responsive to, especially early on. When we see these problems early, we should be thinking about something other than typical Parkinson's disease. And I think that's an important point as well, as you mentioned, in terms of looking for some of the early symptoms or signs. We want to be able to identify some of these Parkinson-like syndromes early on, because they don't respond well to the same types of therapies. Again, other things that we see, or again, as was mentioned in terms of patients who have Parkinson's disease, they're often seen because of a increased incidence of falls, and poor nutrition sometimes accompanies the condition because of difficulty swallowing, difficulty getting to have adequate nutrition, weight loss, and a loss of muscle mass. So these are problems that may come up, unfortunately, and may, if the condition has not been recognized or managed effectively, may be the first signs that come to medical attention that someone may have this neurodegenerative disorder. The same may be true for some of the non-motor problems, depression, psychosis, other psychiatric issues, and so on. We hope that we're able to avoid the presentation of some of those problems, and certainly to address them early on if they are problematic.
Dr. Today, Allen, you mentioned in your initial comments that we're looking at an aged population as well as medication compliance. Any other challenges from a medication standpoint?
Many other challenges exist also from a medication. I mean, just the route, patients with Parkinson's disease, sometimes they lose their dexterity, right? Especially if their tremors are uncontrolled or if they're in some of those off periods. So it's important to be sure that these patients are receiving medications in ways that in a way that they're able to open the bottle, right? Making sure that they have an ability to open the bottle and to get access to those medications without it being difficult. Just the sheer amount of pills many of these patients have to take on a daily basis can be very overwhelming. And it's important to not just address adherence the first time you prescribe a medication or the first time a patient starts on it, but it needs to be at every single visit that you assess their adherence, and not just as a yes or no, are you taking your medication? It needs to be more of an open-ended, how many times do you forget to take a dose in a day or in a week? Another challenge with patients who have Parkinson's disease is that if they start developing some of that cognitive impairment, they're going to need some reminder kind of tactics or techniques to be able to remember, well, did I take that dose or did I not take that dose? And even if you want to give them like a medicine box, not all medicine boxes are the same. Some of them are actually very difficult to open. And so you can't just, it's very difficult to tell a patient, oh, just go get a medicine box. No, it really needs to be something that needs to be thought of, curated, and really, specifically for these patients that are going to have problems with dexterity, could have cognitive impairment. And also not just the patient, but also how do you communicate with the caregiver to help them better understand and engage them if they're able to help with the care for their loved one as well. So
Right.
it's definitely just to highlight again, it's one of those disease states where you're counseling a patient every time you see that patient. And sometimes not just when you see them, but in between visits, because it's something that really needs to be followed on an ongoing basis to ensure that you're proactively addressing some of these issues that are likely to come up.
And Dr. Yagi, do you have any insight as to the challenges that you face as a specialist seeing a Parkinson's patient?
Yes, there are so many challenges, from start to finish. We think about the diagnostic challenges, the diagnostic journey. That question the answer to that question is very much about the therapeutic journey as well. Similar to what Dr. Today Allen was mentioning, the pill burden for our patients is very, very complex. It's a very high pill burden. You can imagine it's hard enough for one patient to take one medication once a day, right? And our patients oftentimes are using a multitude of therapies. They use a combination therapy approach, cocktail-like approach. We analogize it to very similar to endocrinology or oncology many times. It's kind of this combination therapy, or what's called rational polypharmacy. This is part of our subspecialty training, is how to utilize medications in unison with each other to complement and augment each other, so that we're doing the best for our patients when it comes to stability. Our goal is to maintain tone, right? We call it a dopaminergic tone. Clinically, that's what we're working towards. How to keep our patients steady throughout their day so that they're not wearing off of their medicine, so that they're feeling like their Parkinson's symptoms over time, over their waking hours and sleeping hours, so that their Parkinson's symptoms are alleviated and well controlled. That is our goal, and that is the most challenging part of keeping our patients feeling good, feeling mobile, walking well. As Dr. Spivak mentioned, our avoiding falls in our advanced age population is so key, even in non-Parkinson's patients. And so our goals are very complex, and sometimes the challenge becomes having a strong understanding and teaching our patients what each medication does. Right? We know carbidopa, levodopa might be our gold standard when it comes to therapeutic options. Patients might be taking carbidopa, levodopa many times a day, sometimes every 3 hours, sometimes more often than that. And so you have to think logistically in terms of pill burden, what's realistic for a patient to keep control of their life, but at the same time, how to use augmenting or adjunctive therapies in order to keep these patients on that right trajectory to maintain that dopaminergic tone. That is the challenge. How do we equip our patients with that knowledge, that know-how, that level of support We say oftentimes in our clinic, it takes a village to take care of our patients. It takes us as clinicians, it takes our geriatric colleagues, primary care physicians, gastroenterologists. I can name so many doctors that it takes just to take care of one Parkinson's patient. And I wish I had a pharmacist that had a strong understanding as part of our practice. I mean, this panel is just wonderful because this is the type of practice that every center should have. You know, a geriatrician, someone who understands our therapeutics, someone who understands our clinical frontline, not to mention the social work necessary, physical therapy, speech therapy, everything non-pharmacologic that Dr. Spivak spoke about is also important. Those kind of augmenting therapies that have nothing to do with allopathic medicine.
You actually just answered my last question, which is what's the therapeutic goal? So I think I'm hearing you say that the therapeutic goal is really a multidisciplinary approach to allowing that patient to maintain a very constant on episode throughout the entire day. Not to put words in your mouth, but that's what I think I heard.
Exactly right.
Dr. Spivak, anything to add in terms of what the therapeutic goal should be, since obviously our medications today are not cures for Parkinson?
Right. Yeah. So again, I think as Dr. Yagi had mentioned, what we're focused on in geriatric medicine, what we should be focused on in medicine, is doing what matters most for patients, doing what matters most to them. And when you talk about outcome measures and so on, for many people, it can be put into words that they tell us what they want to be able to do that they cannot do now. And, you know, again, we need to be satisfied and try to promote goals that may be realistic. Maybe they're small goals to start, but, you know, that's how we grow. And we need to try to convince people that they can do better. For example, in terms of fall prevention, as was discussed, it's very important, I think, to engage physical therapy early on when someone presents with Parkinsonism, because there's much that can be done by physical therapy alone, physical and occupational therapy, but rehab techniques can be very beneficial to try to improve the individual's what's called efficacy, or their ability to feel comfortable getting out and walking, and not to be shut in or isolated or restricted significantly in terms of mobility because they're afraid of falling, or they're afraid of going out because they'll maybe have a problem in terms of motor function where they turn off, for which we'll hear about, and cannot manage any longer. And it's not only embarrassing, but it could be dangerous if it's when you're driving a car, or, you know, doing something with some other potentially dangerous equipment, for example. For many people, this is it has an impact negatively in terms of socialization. So we know about the dangers of isolation. We've learned a lot more about that because of the pandemic, especially in older adults. And we're trying to minimize that sense of isolation, that sense of being out of touch. For people with Parkinson's, again, not having normal ability to do the everyday tasks that we take for granted becomes a significant barrier to them and to their families that are confronted with trying to address those needs for them. There are many, many challenges. I remember when I was a medical student a long time ago and worked with an individual who was then the chairman of neurology at Mount Sinai, Dr. Melvin Yar. And you may have heard about the staging of Parkinson's that is characterized often by his staging. The focus that we had then was trying to understand how best to use basically the only medication that really existed at that time, which was levodopa, and to try to minimize the motor fluctuations by learning a little bit more about how people can successfully take care of their mobility problems using this medication effectively. Now we have a lot more to choose from, as Dr. Yagi indicated, in terms of specific medications, not just levodopa type medications, but dopa agonists, other enzyme therapies, other approaches, which we'll learn more about in terms of trying to minimize some of these off episodes which deal with therapy on demand needs, as well as surgical approaches, which never existed previously. So there's much that can be done. And I think the importance is to try to ensure that individuals who have this condition are effectively offered therapies that have been proven to be beneficial and can make a significant difference in their daily lives.
Great. And Dr. Today Allen, your thoughts on therapeutic goals?
So to add on to the comments already by my other members of the roundtable, Dr. Yahi spoke about rational polypharmacy, but regular bad polypharmacy still exists. And so especially with all the direct-to-consumer advertisement and the fact that most Americans don't have a good enough really health literacy to understand how different medications can impact each other as well as their disease states. And so you may have a patient that sees an ad on TV, goes on a website and orders a medication, or sees an online physician that may not truly understand how to best manage patients with Parkinson's. And so it's really important that that kind of review of medications and ensuring that patients are not taking additional medications that they may not necessarily need, or that are going to interact with their existing treatment therapies or make their disease state worse, is again something that needs to be addressed, again, ongoing, not just once a year or one time when you see the patient.
Thank you. This concludes the first part of our three-part roundtable series. In part 2 of our discussion, we will take a deeper look at the available management strategies. Thank you to our faculty for your insights, and a special thanks to our sponsor, Synovian, and to First Report Managed Care for making this video possible.